Hello friends, now I will be talking to you about acute myeloid leukemia. AML is the abrupt onset of malignant transformation of myeloid stem cells in the bone marrow, and the common age of AML is between 25 to 60 years is the age. It is more common in Down syndrome, Klinefelter syndrome, and Turner syndrome. Now, let's see how we classify AML. We have FAB classification. We have M0, which are also known as minimally differentiated. They are myeloperoxidase negative. This is a very important point. Then we have AML without maturation M1. Here only 3% are myeloperoxidase positive. M2, they are AML with maturation. It was without, this is with maturation. This is the most common type of AML. Classically in these T821 translocation is seen, and IU rods are positive in these cases. M3, promyelocytic AML, M3, very important point. In this DIC is common. IU rods are present, and classically we see M15-17 translocation. In M3 variety, there is abnormality in the retinoic acid metabolism. That is, vitamin A metabolism is abnormal. That's why in the treatment of M3 we use ATRA. ATRA is all trans retinoic acid. Myelomonocytic is M4. It is more associated with INV16. Monocytic M5, it typically involves the older people, and patient has gum hyperplasia. Erythroleukemia is M6 variety. It's classically most common in therapy rated acute myeloid leukemia, and the M7 is megakaryocytic leukemia. M7 myelofibrosis is very common, more commonly seen in below 3 years in Down syndrome. Remember, something unusual, because the common age of AML is between 25 to 60 years, but this can occur in children also. So the main highlights of this table is MP negative, MP 3%, and this is most common T821, DIC, M15-17, ATRA, INV16, gum hyperplasia, therapy related, myelofibrosis, and in children. These are the important points that you should remember. Well, we have seen the classification of AML, and now we talk about what are the important points in the pathology that you should know. So in the pathology, when we see the peripheral smear, you get eosinophilic granules in AML. Just for your recall, eosinophilic granules are not there in ALL. IE rods are present, TT is positive only in 5% no pass positive material. Remember, TT was positive in 95% cases of ALL, and pass positive material was seen in the ALL, but these two are not seen in AML. And of course, myeloperoxidase staining is characteristic. This I discussed also. MP is very characteristic of AML. Now, what are the clinical features? Patient usually has abrupt onset. And what happened? Because it's a disease of the myeloid series in the bone marrow. So abnormal cells are multiplying very fast. That's why normal RBCs is reduced, normal TLC reduced, normal platelet are reduced. So it leads to fatigue or anemia. This leads to prone to infections, and this leads to bleeding tendencies. In fact, these three symptoms are also seen in ALL, all because of suppression of the normal WBC, RBC and platelet. What else we see in AML? We see chloroma, solid mass are seen, gum hyperplasia are seen in patient of AML. Testis involvement and CNS involvement are not a prominent feature of AML. These two, that is testis involvement and CNS involvement, is more common seen in ALL. And like ALL, here also we have generalized lymphadenopathy, liver and spleen are enlarged. Now we talk about investigation. Best investigation, best initial is complete blood count, peripheral smear where we see blast cells. But most important is bone marrow examination where we see blast cells. Blast cells are more than 20% in the bone marrow, and of course in the peripheral smear also. And we do flow cytometry to know the type of subtype of leukemias, and it also tell you the various CD markers present on the surface of the cells. Then let's see what are the prognostic factor. Poor prognostic factor, so-called high risk cases. Remember, single most important prognostic factor is cytogenetic abnormalities. So let's see what are the poor, good and intermediate risk factor or cytogenetic abnormality. So remember, poor prognosis or so-called high risk cases. The cytogenetic abnormality are complex karyotype, INV3, monosomy 7 and 5 and del 5q. They are high risk or with poor prognosis. Other are age above 60 years, high LDH level or expression of MDRI gene, very high TLC count at the time of presentation, and failure to achieve complete remission after the induction therapy. They are the high risk or poor prognosis. High risk means the high chance of relapse. Good prognosis, so-called low risk of relapse. T821, INV16, T1517 and M3 variety. They are the good prognosis. Intermediate prognosis is no cytogenic abnormalities. So now we start treatment. We treat the supportive therapy for nutrition, antibiotic, and other and anemia. Then the specific therapy for induction phase is cytosine, arabinocyte plus daunorubicin or idarubicin. This is what we give in induction therapy. Well, but in M3 variety for maintenance we can give Atra, or in resistant cases we even can give arsenic also. Now what happened? Once we have done the induction phase, after that in low dose, low risk patient, these patients, for consolidation we use high dose cytosine. But in intermediate variety, these patients, we use allo or autogenic bone marrow transplantation. But in poor prognosis or so-called high risk cases like this, we always go for allogenic bone marrow transplantation. This is all about acute myeloid leukemia. Thank you very much.